Welcome to ALS 101. So we have our care services managers from the state of Florida here. We have Charlene Caro. She's our care services manager in Southwest Florida. She serves around 230 people living with ALS and attends Lee Health and Sarasota Memorial ALS clinics as the clinic liaison. Kimberly San Martin, she's will be here shortly. She is our care services manager in Miami-Dade and Monroe County, and her territory is around 200 people living with ALS. Kim attends the University of Miami and Nova Southeastern University ALS clinics as the clinic liaison. Melissa Alsame is our care services manager in Northwest Florida. She serves around 150 people living with ALS, and she attends the UF Gainesville Clinic at the Normal Fiscal Institute. So there are pens and paper for you guys to take notes. There is a survey, if you would take that with you and fill that out, and you can turn that in at the care services table or at the check-in. And we welcome everybody's input. And let's get started for the presentation.
Good morning, all. So we're going to play the presentation that does have an audio, and we're going to leave the questions and answers for later.
Our objectives for this presentation is to discuss the forms, the onset, and cause of ALS. We will also be looking at the diagnosis, the symptoms, and progression of ALS. I will also be reviewing information about treatment that's available and also care options that are available for people living with ALS. I will also be providing an overview of our chapters, programs, and services. What is ALS? ALS is an acronym for amyotrophic lateral sclerosis. It is sometimes referred to as Lou Gehrig's disease in the United States, and in other parts of the world may be referred to as motor neuron disease. ALS is a neurodegenerative disease of the motor neuron cells, which are located in the brain and the spinal cord. Motor neurons are responsible for transmitting impulses or signals to the muscles in our body, which control voluntary movement. As ALS progresses, the motor neurons degenerate, and this leads to a loss of muscle control. This results in patients with ALS developing paralysis in their limbs, losing their speech, losing the ability to swallow, and eventually losing the ability to breathe. Life expectancy for ALS is 2 to 5 years on average, but there are people who live more than 5 years, 10 years, or even 15 years or longer with ALS. At this time, there is no cure for ALS, but there is always treatment, help, and hope to help manage the symptoms. Frontotemporal dementia is a rare form of dementia that affects the frontal and temporal lobes of the brain, and this causes difficulty with decision-making and sometimes changes in behavior and personality, as well as language dysfunction. About 20% of people living with ALS have frontotemporal dementia, and this comes in varying degrees of severity. But up to 50% of people with ALS may actually experience some mild changes in their decision-making and their behavior. ALS has long been known as a disease that affects the body but leaves the mind intact, but recent research has led us to believe otherwise. So examples of personality and behavior changes with ALS and FTD are being less sensitive to the needs of others or being withdrawn. Some patients may display cheerful or childish behavior. They may become fixated on one idea or activity, and unfortunately in some cases they may also become aggressive or disinhibited. So who gets ALS? The prevalence of ALS is 4 to 6 per 100,000 population. which gives us a total of 13 to about 20,000 people living with ALS at any given time in the US. Incidence, which describes new cases per year, is about 2 per 100,000 population, so approximately 5,000 to 6,000 new cases per year are diagnosed. Looking at the total US population number, the prevalence of ALS would be around 13 to 20,000 people. ALS most commonly occurs between the ages of 40 through 70, and men are slightly more affected than women. There are two types of ALS. The first is familial, which indicates a family history of ALS, and the second is sporadic, with no family history. Familial cases make up 5 to 10% of all ALS cases. There are more than 25 genes that have been identified that are associated with familial ALS. 90 to 95% of all ALS cases, however, are sporadic, with no known cause. Military veterans are twice as likely to be diagnosed compared to the civilian population. And possible environmental factors are smoking, physical activity, toxic chemicals, and heavy metals. The established risk factors for ALS are older age, so the older a person gets, the more likely they are to develop ALS, being male, and having a family history of ALS. It is most likely that environmental factors are not sufficient to cause disease, but they may actually work in conjunction with someone being genetically susceptible to ALS. It's been very challenging to identify and confirm that environmental factors are linked to ALS. Exposure to toxins or the influence of intense exertion or exercise are potential risk factors thought to explain the occurrence of the twofold increase in military veterans, but also attributed to the many sports players that develop ALS. However, at this time, these findings are not conclusive. Looking at how ALS is diagnosed, there is actually no specific test that identifies ALS. ALS is diagnosed through a series of tests and clinical exams that actually rule out or eliminate other diseases that mimic ALS. Upper motor neurons are nerve cells that travel from the brain to the spinal cord to control movement. When they are lost, people experience stiffness in their limbs, brisk reflexes or hyperreflexia, and weakness. In addition, loss of motor neurons in the spinal cord or the lower motor neurons, these are the nerves that run from the spinal cord to the muscle. Loss of the lower motor neurons causes weakness, muscle wasting or atrophy, and muscle twitching, also known as fasciculations. To diagnose ALS, there should be signs of both lower motor neuron degeneration and signs of both upper motor neuron degeneration. Looking at the types of onset, there are 3 types of onset for ALS. 25% of ALS cases have bulbar onset. Symptoms here start with changes in speech and swallowing, so patients experience choking, aspirating, excess saliva, changes in speech, and sometimes uncontrollable periods of laughing and crying. About 75% of ALS cases are limb onset, which means symptoms start with weakness in an arm or a leg. Common symptoms here are tripping and falling, dropping things, abnormal fatigue in the limbs, inability to perform daily activities of living, muscle cramps and twitches, and sometimes weight loss as well. Very rarely, patients may experience thoracic onset, where the first symptoms are difficulty breathing, shortness of breath, and a weak cough. We will now look at some disease-modifying treatments and care that are available for ALS. The first is Riluzole or Rilutech, which is an FDA-approved drug for ALS. It's an oral medication that is said to prolong life expectancy by 6 to 21 months, depending on the type of study you look at. The second FDA-approved drug for ALS is Radicava, also known as Edaravone. This is an intravenous infusion type of medication. It may slow progression in a select group of patients. The third FDA-approved medication is Nuedexta. Nuedexta is used for the treatment of pseudobulbar affect, or inappropriate laughing or crying. Clinical trials are also available at multidisciplinary ALS clinics. Another disease-modifying treatment is non-invasive ventilation, which is said to increase life expectancy by about 10 to 13 months compared to patients who do not use non-invasive ventilation. Another disease-modifying treatment is gastrostomy tubes or feeding tubes, which are said to improve life expectancy if placed at the right time. Multidisciplinary care is also a disease-modifying treatment. It is associated with increased life expectancy of about 6 months. This is most likely due to sooner treatment with non-invasive ventilation and feeding tubes. Care that is provided through such clinics can reduce injury, promote safety, increase mobility and independence, and also prevent and alleviate physical and emotional pain. A visit with a neurologist alone does not allow enough time to address all the needs of the patient in just 1 hour. In a multidisciplinary clinic, patients are given 3.5 hours of dedicated time with each specialty to address the physical and emotional challenges that are associated with ALS. These clinics include visits with a neurologist, a physical therapist, an occupational therapist, a respiratory therapist, a registered dietitian, a speech therapist, a social worker, and an ALS Association chapter liaison. Clinics may also bring in wheelchair vendors that are readily available for any needs. With all specialties being in one location, it will reduce the out-of-pocket costs that would accompany individual appointment visits. This also reduces the amount of travel for the patient, which becomes very difficult once the disease progresses. Telehealth or telemedicine visits are also available for patients who are bedbound and are unable to attend clinics in person. We will now look at some symptoms that present with ALS. The first is with bulbar symptoms, where ALS patients develop difficulty speaking due to weakness of the tongue and the diaphragm. It should be noted that strength-building exercises are ineffective and may actually worsen muscle fatigue. Some tips for enhanced communication is to converse in quiet environments, limit distractions, sit face-to-face with the patient in a well-lit room so that you're able to read nonverbal cues. Repeating words you understand is also effective. This strategy will help patients not to overuse their muscles and conserve their energy. Technology also exists that could help. Voice and message banking are options that are available that a person could take advantage of, especially early on in the disease. Voice banking allows a person to record a set list of phrases with their own voice to create a personal synthetic voice, which can later be uploaded to a speech-generating or communication device. Message banking allows patients to record and bank personalized messages that may include their humor or tender messages to loved ones. An augmentative and alternative communication device evaluation is important. So meeting with a speech therapist to discuss what methods, devices, and techniques will work best for communication are important for a person living with ALS. This page provides samples or examples of low-tech AAC devices. Items include an alphabet board, a picture board, an E-Tran board, a voice amplifier, and a boogie board, which is a kind of modern Etch-a-Sketch. The examples on this slide are high-tech communication devices, which include eye gaze devices, where a patient can type using their pupils. They can access computers using a head mouse. There are also several text-to-speech apps that could be downloaded on phones and tablets, some of which are free. This page provides you with additional resources for communication, including demonstrations. Some safety concerns for bulbar onset ALS are choking, aspirating, excess saliva, dehydration, and weight loss. Interventions are changing the consistency and texture of foods, teaching swallowing techniques, medications that are available for excess saliva, and feeding tubes that would provide nutrition and hydration. Swallowing with ALS becomes impaired as the muscles that help propel food and liquid down the esophagus become weak. Some early signs of swallowing difficulty is throat clearing, coughing when eating, taking longer to complete meals, and increased saliva. Some concerning signs to look out for are choking, aspirating, and respiratory infections, which could be caused by food going down the wrong way. It's important to report both early and the more serious signs, as they should be followed up with a modified barium swallow study. Some recommendations for safe swallowing is to encourage patients to sit upright, to eat slowly, to take small bites and chew their food thoroughly, to avoid talking with food in their mouth, encouraging them to eat with a companion, making sure to clean their mouths after eating, and remaining in an upright position for 20 minutes after eating. This obviously may not apply for all patients. Oral care is important for people living with ALS. Toothbrushing, mouthwashing are sometimes forgotten as patients develop limited mobility and difficulty swallowing. Oral care is important and should be done between meals. Excess saliva in the mouth can cause tooth decay and gum disease, which increases the risk for infection. Specialty mouth swabs are available. There are also toothbrush attachments that could be used with a suction machine for a more thorough oral care. Patients with swallowing difficulties usually experience more and thicker saliva. Tips for when saliva becomes thicker and harder to swallow is to swallow more frequently, but slowly and carefully, avoiding sweet and very sour foods that tend to stimulate the salivary glands, and increasing fluid intake to thin out secretions. There are also prescription medications available to help if needed. The PEG tube, or the percutaneous endoscopic gastrostomy, also known as a feeding tube, a G-tube, or a Mickey, is an alternate route for providing nutrition, fluids, and medications. It is placed surgically and may have associated risks. It is useful for stabilizing weight or actually gaining weight. Studies have shown that it prolongs life expectancy in ALS patients. It reduces the risk of choking as well as the risk for dehydration. It is important to note that having a feeding tube does not prevent a patient from eating by mouth if he or she chooses to do so and can do so safely. And once it's healed, the tube does not limit usual activities. When is it time to get a feeding tube? Signs that tell us that it is time to discuss a feeding tube are excessive weight loss, food going down the airway on a regular basis, which is shown by choking and coughing with meals, the progressive inability to swallow, fatigue with eating, and respiratory function that is less than 50% of normal for the individual. It should be noted that not all patients opt to get feeding tubes. Patients should discuss risks and benefits with their healthcare provider and develop a plan to manage discomfort if they opt against a tube. We should respect a patient's decision either for or against getting a feeding tube. Looking briefly at diet and nutrition, not consuming enough food will lead to the body breaking down its own muscle and fat. So the goal with ALS is to maintain body muscle and fat by eating enough calories. It's important to maintain good nutrition because that also means more energy, a stronger immune system, and an overall better sense of well-being. Malnutrition, on the other hand, causes weight loss, loss in strength, increased fatigue, and an increased risk for skin breakdown. Protein, should be mentioned, is an essential component to the diet in ALS patients because it provides the building blocks for muscle. The goal with ALS is to eat enough calories, and foods high in fat and sugar are good sources of calories. Every patient should aim to maintain their body weight and never attempt to lose weight, even if they feel that they are overweight. Extra weight with ALS is considered to be protective in living longer. Patients are encouraged to weigh themselves weekly and to watch out for any changes in weight, especially loss. If a patient notices a decrease in weight, the first step is to try adding more calories to the diet. And if the weight still continues to drop despite diet changes, then it's time to consult with a dietitian who will work on a meal plan. Maintaining excellent hydration is also greatly encouraged. If thin liquids are safe and the difficulties because of mobility, consider use of a sports cup or hands-free hydration pack like a Camelback. If thin liquids are not safe, liquids should be thickened using commercial thickeners. Constipation is a common complaint with ALS. It occurs due to weakened abdominal muscles, and it's made worse by the person being immobile or being dehydrated and also being on a low-fiber diet. Some strategies to reduce constipation are walking, as much as that is possible, increasing fiber intake, and maintaining good hydration. There are also many types of medications available. Patients who have mobility issues may benefit from having a specific time of day to have a bowel movement. If constipation is uncontrolled, it's best to contact a healthcare provider. Moving on to limb weakness, some safety concerns are falls and the inability to perform activities of daily living and skin breakdown. Some interventions include canes, walkers, braces, wheelchairs, other assistive equipment and devices that help with activities of daily living, adapting one's bathroom for safety, positioning in order to prevent pressure sores, energy conservation, and range of motion exercises to prevent contractures, and stiffness. ALS is an energy-consuming disease, so traditional physical therapy could be exhausting and counterproductive. The main focus of physical therapy should be on range of motion and not on weightlifting or repetitive exercises. Rebuilding strength and muscle mass should not be the goal of therapy. Some achievable goals with ALS is to maintain strength as long as possible without causing exhaustion, reducing swelling, maintaining range of motion to prevent joint pain, learning safe transfer strategies, learning the proper usage of assistive devices, and also learning strategies to prevent skin breakdown. Risk factors for developing pressure ulcers are immobility, malnutrition, and incontinence. Common areas are the sacrum, the buttocks, the heels. Prevention is frequent position change. Managing pressure ulcers is done through barrier creams, bandaging, wound care nursing, and alternating air pressure mattresses. Contractures, or the shortening of muscle or joint due to lack of movement or spasticity, can be painful. Common areas for contractures are the shoulders and the hands. They could be prevented with range of motion exercises and splinting. They could be managed through occupational therapy and pain control. This slide shows mobility and gait devices. This slide shows equipment that could be used in bathing and toileting. This slide shows assistive devices that help with completing daily living activities. Moving on to respiratory care, some signs of breathing difficulty are needing to elevate the head to breathe when sleeping, so using more than 2 pillows, morning headaches caused by increased carbon dioxide buildup in the body, frequent waking, difficulty staying awake during the day, shortness of breath, and a weak cough. We shall also be looking at some interventions that help with breathing difficulties. Shortness of breath is the result of weakening of the diaphragm muscles, the work of which is to push air in and out of the lungs. If there is no secondary lung disease that affects the air sacs, the reason for decreased oxygen levels in ALS is lung muscle weakness. This is the reason why oxygen and other inhalers are not helpful treatments for people living with ALS. Ventilators can be used to assist with shortness of breath. In ALS, it's important to note that oxygen administration may actually be detrimental if it is used in place of bi-level or non-invasive ventilators. It's important to report sudden worsening in shortness of breath or need for ventilator, as these can be signs of respiratory infection. Other signs to look out for are a cough, fever, chest congestion, etc. Non-invasive ventilation is ordered to assist when breathing becomes more difficult. Symptoms of excessive carbon dioxide are morning headaches, daytime fatigue, frequent nighttime awakenings, and nightmares. Most patients begin using ventilation at night while they're sleeping, and they gradually start using their ventilator more during the daytime as their disease progresses. When started early, non-invasive ventilation is proved to extend life by 11 months. It brings about significant improvements in quality of life, energy, and shortness of breath. A suction device is provided when a patient starts to have increased saliva that requires frequent use of towels or tissues to collect the extra secretions. A suction device allows patients to easily remove the excess saliva and reduce the risk of choking or aspirating. It can be attached to power wheelchairs for convenience. A cough assist device is a device that clears the airway and helps breathing by clearing phlegm and fluid-like secretions from the lungs. It simulates a natural cough by applying positive pressure to inflate the lungs before using a vacuum-like suction to pull everything up. Regular use can maintain the strength of the diaphragm and help prevent infections like pneumonia and bronchitis in people living with ALS. Tracheostomy and invasive ventilation are used when non-invasive ventilation with a mask is no longer effective. Patients will need to choose between getting a tracheostomy and mechanical ventilation or hospice care. This is a very personal decision that is best made ahead of time. A tracheostomy is a surgical opening in the neck through which a breathing tube is inserted directly into the windpipe, and a ventilator is then attached to it. Patients on ventilators with invasive ventilation require 24-hour care. Some psychological factors to consider in patients living with ALS is depression, anxiety, cognitive impairment, behavioral changes, frontotemporal dementia, and pseudobulbar affect. Potential symptoms of depression include prolonged feelings of sadness, hopelessness, worthlessness, anxiety or guilt, irritability or angry outbursts over small matters, changes in sleeping patterns, including insomnia or sleeping too much, changes in appetite, fatigue. For ALS patients, these symptoms are not as clear-cut. For example, fatigue could be a symptom of depression or a result of muscle weakening caused by ALS. Changes in appetite also could be caused by increased difficulty in chewing and swallowing food, or by a decrease in physical activity resulting in less calories being burned. Because of this, it's important to make sure a doctor or a psychiatrist can determine whether a person living with ALS is suffering from clinical depression or not, and prescribe treatment if needed. Pseudobulbar affect, which is a symptom of bulbar onset ALS, which brings about uncontrollable or inappropriate outbursts of crying or laughing, which is not consistent with a patient's overall mood. This does not occur in all patients with ALS, but it can sometimes be distressing for patients with ALS. Nuedexta is an effective treatment, and it can be prescribed if PBA is disrupting a person's quality of life. Not all patients experience these symptoms, but early identification and management are important to the quality of life of the patient. So what does the ALS Association do? We work to serve, advocate for, and empower individuals and their families who are affected by ALS. The services that we provide include patient education programs, referral services through telephone and email, education, information and support for caregivers and family members, referrals to multidisciplinary ALS clinics and other medical providers, support groups that are virtual at this time, an equipment loan program. We house equipment like walkers, wheelchairs, ramps, hospital beds, and the like. We have loaner communication devices and an assistive technology program. We have a quarterly financial assistance program that helps with respite.
Wasn't it?
with home or vehicle modification, medical expenses, transportation to multidisciplinary clinics. Our association also, this slide provides resources and links to additional information about ALS. Thank you.
Okay, if nobody wants to ask questions, we'll be on the side over here. If anybody feels they want to access individually, we'll have that opportunity as well for you guys. Okay, thank you so much for joining us this morning and coming to this event. And if you could do the survey by chance, that's, I believe you guys have it in front of you. You could take the time to do that as well. Thank you.
Thank you, ladies. Thank you, everybody. So if we sure we don't have any questions, we are going to, in 5 minutes, have a presentation next door. The presentation that was originally scheduled for the next time, this next session, the speaker had a car emergency, so we will not be hearing on estate planning, but next door we will be hearing, let me get that for you, on access to environmental controls. So that will start at 9:25, and that will be in the main room.